Good afternoon, everyone. Welcome to our weekly Native Strong Town Hall on the COVID-19 response. And now as we move into another week of vaccine rollouts and distributions throughout the country within the Wisconsin area, Native communities all over, kind of just dealing with the impact of how those are being rolled out, where and when they're being rolled out. And as Dr. Nace will talk or speak on today, the phase 1B, which Wisconsin has kind of mentioned should be around March 1st. And we'll be discussing, what that impact has on your community and the state as well. If you've been on these before, we love questions. We welcome questions. If you're joining us via Zoom, there's a little chat bubble at the bottom of your screen or the top of your screen, depending where you move your cursor, I believe. Little chat bubble, looks like a talking bubble. Put a comment in there and we will get through that at the end of our session in our Q&A. Our moderator, Mark Denning here, usually does a great job of getting through those and kind of picking apart and getting those to our speaker, Dr. Lyle Ignace. If you are joining us via Facebook, just drop in a comment and we will moderate those as well. I mentioned Mark Denning. Thanks for being here again with us, Mark. And with that, I'll pass it along to you.
And the open and Jabba. That greeting is about welcoming our ancestors right now, our present, certainly going into the future. And this is a native to native conversation. Included in my introduction was not just us as beings, but all of those flyers and all of those folks that are outside these windows. And especially you for viewing. Thank you for being here with us and to get that good information. If you do have a question that occurs to you in the midst of the presentations, please use that chat bubble so you don't forget it, or write it down if you can. Just hit that and just put that in and we'll get to that question right away. Remember, as we go into our week here session, ask questions for the people who can't. Ask questions for the people that you run into and maybe you're not explaining things or meeting them where they're at. Because they may not have the advantage of having a computer and looking at the latest articles, understanding the latest science, because it's just not available to them. They don't have internet. They're going to websites that don't have responsible introduction. But that's why we're here. That's why Dr. Ignace is doing that, and he's here. This is a native to native conversations, native-based community, and he's here for an hour. And I don't know how many of you get to visit with a doctor every hour, every week, especially just on this subject of COVID-19, its effect on our communities, how it can be better. So let's turn this over to Dr. Ignace to give us the latest information and especially for community leaders, what's coming so we can be in front of it. So Dr. Ignace, a lot of concerns. We just had a native event across the border. Everybody's having a round dance, singing, getting together, and we're seeing it, and we're hearing conversations. So we'll get to that later. But Dr. Ignace, over to you, and let us know what's happening out there. Thank you.
Thanks, Mark, and thanks, Jeremiah. This is week 47. Yeah, this is like a house call. They used to not do those anymore, but I'm talking to you personally, so consider this a house call and just a personal connection to get you up to date on what's going on in COVID. These are the main outline framework for the vaccines that are currently out there. Moderna, Pfizer, we all know about that. What's new, and it's what's going to come down the pipe very, very soon, is Johnson & Johnson. AstraZeneca is still kind of off into the distance here a little bit, but Novavax also will be making headway here as well. So let's get into some information, because I know people would want to ask about what's going on. Personal questions. So So this was Pfizer, Moderna. They're coming out with all new things, wondering about the latest questions about efficacy and safety and whether or not their vaccines can manage the new strain variants. And so Pfizer partnered with the University of Texas Medical Branch, and they looked, University of Texas genetically modified the engineered versions of the COVID-19 to resemble the South African variant. And so looking at how individuals from 15 people matched against this genetically in lab kind of test sample. They looked at the blood samples and they noticed that individuals' blood tests produced fewer neutralizing antibodies. Now, what that means is that the individuals, their antibodies weren't an exact match. It's like trying to, maybe put it this way. Let's say you wear size 10, you have size 10 foot, and you're trying to put your foot in a size 14. Yeah, it'll fit, but it's not a perfect match. So to kind of put it simply, it works, but not to what the efficacy of the original virus is. And so, but at the same time, what they're saying, there's no clinical evidence to date that the South African variant virus escapes the vaccine protection from COVID. So this is encouraging in that that it does have an effectiveness against the virus, but what we're not sure and what they can't quantify is what that level of effectiveness actually is. So they feel it works and it feels it is protective, and they just can't tell us at what level just yet. So I know I presented this last week, but it's a good reminder as a comparison, because this is going to come up. This is going to come up, and people are going to be faced with decisions about which vaccine should I get. Pfizer, Moderna are out. Johnson & Johnson just came out in the last 24 hours that on February 26th, they are going to go before the FDA and the emergency use authorization process. February 26th. So if they get approved, we could look at a distribution as early as March 1st, which would be Monday. So what's important to know is what, you're going to be presented with vaccines of different technologies, different efficacies, different protections against the B117, the B1351, the Brazilian, the California variants. So there's multitudes here, and it really will come down to perhaps preference, understanding how these vaccines work, how effective they're going to be. So Johnson & Johnson more than likely is going to get approved. I don't see or have found any information to suggest otherwise. And so their vaccine is going to be ready for distribution and be in the system just like Moderna and Pfizer. And as I had mentioned last week, we can see that the efficacy is about 72%. What they're not sure about the efficacy against the UK B117, they actually feel that it is about 70%. It's about 70%. They're not, they haven't formally made that announcement, but that's their efficacy. The benefit of this vaccine is that it's one shot. In terms of storage, it can be put in the refrigerator. Its shelf life is much longer than Moderna and Pfizer, 18 and older. And so as a one shot, after 28 days, it has 85% effectiveness against severe COVID symptoms and 100% after 90 days after you've shot. So, you know, in short term, you'd be wondering about its effectiveness, but after 28 days or even after 3 months, its effectiveness goes up long term. So this is really this is going to be a really good vaccine, and as a one-time shot, you know, side effect profiles haven't come out yet, but I'm pretty sure it's going to be pretty much similar to what Pfizer and Moderna are profiling. So as a one shot versus two shot, yeah, this may be a better fit for most folks. They may not want to go back for a second shot or have even the capability of going back for a second shot. Maybe they're missed their opportunity, that window. So J&J actually may be a better option for folks moving forward here. So the downside to Johnson & Johnson, and the government had entered into an agreement for 100 million doses. The problem is they don't have 100 million doses up front, and that it's actually going to take a while. In fact, they only have a few million doses. And so it's going to take a while to mass produce the volume that has been agreed on. So, you know, with the approval of Johnson & Johnson, it's going to be a few drops in the bucket here in getting things moving. But as time goes by, they'll be have a much bigger role in getting the general public vaccinated. So what's going on here in Wisconsin, I'm sure people are becoming more and more aware. Right in the middle there, it says 12.7%. 740,000 individuals have gotten at least one shot here in Wisconsin. You can see the race breakout. American Indians 8.3, Asians 5.5, blacks 3.5, and whites 11.9, Hispanics 3.4. So that's at least one shot. People who've completed 2 shots, 4.5%. You can see what the breakout in the demographic numbers there on the right lower hand corner. Now, the states continues to get vaccine on a regular basis. It seems to be tapering off a little bit. And the only reason why I say that is if you look right in the middle, you can see I put a little table here of the dates, January 19th, 26th, 2nd. Right below that, the number of administered vaccines and number of shots actually given, and then what the 7-day average has been. So it did ramp up to 32,000 on February 2nd. The following week down to 30,000, and then this past week falling below 29,000. So there seems to be a tapering off here a little bit of Pfizer and Moderna in circulation here in Wisconsin. So, but that was to be expected. These companies are asked to produce millions and millions of doses, not just for the United States, but for worldwide. So it's gonna take time. This isn't going to be instantaneous stuff. So it's going to take time. And with the demand continually going up, it's going to be a challenge to keep up with that demand. So it kind of brings into more recent what has been announced here in the last 24 hours. Is Wisconsin's eligibility approach, the framework approach to phasing in who's eligible. And right now, phase 1B is being kind of highlighted to be open March 1st of next week. Now, just as a review, phase 1A, that was frontline healthcare individuals, residents, and staff of nursing home and long-term care facilities, police and fire personnel, correctional staff. And what was mixed in there, or it was originally like 75 and older, but executive orders changed that to 65 and older. Now, we had a little more clarity with phase 1, not just identifying the groups of individuals and age demographics, but we also had an idea of the actual number of individuals, and it would be about 700 to 800,000 people in that first phase 1A. What has been announced is the next phase, 1B, and the eligible groups are education and childcare individuals, people that are enrolled in Medicaid long-term care programs, some public facing essential workers, non-frontline essential healthcare personnel, facility staff, and residents in congregated living situations. So when you look at that, he's like, oh man, that's kind of very broad. And it is broad. And so when I looked at more specifically, what does this entail? You can see how broad this actually gets and how difficult it's going to become to identify who fits into all of these categories. So you say, well, let's just go through educators and childcare. Well, all staff in regulated child care, public and private school programs, out of school time programs, virtual learning, and community learning center programs, boys and girls, YMCAs, Head Start, K through 12 settings, faculty and staff in higher education settings who have direct student contact. So higher education, I suppose there needs to be a little more clarity. Does that include, are we talking high school or are we talking college, universities? So there needs to be a little more clarity, but as you go through each block, you start to see that more and more people are going to be added and integrated in this. And it's going to become more and more confusing because we've opened, the keyhole here to a wide open, not wide open, but a very another select group. We don't know, I don't know, it hasn't been publicized as to how many people fit into this category. Is it 700, 800,000 again? Is it 2 million people in these categories? I don't know. And so that's going to be the difficult part, is how are we going to identify individuals who fit this category? Because people could call their local health department or maybe even their or a healthcare facility and say, hey, I'm part of the food supply chain. I'm considered a critical worker, and how are agencies going to verify individuals' employment? And it's just going to be a little difficult. Not saying that it can't be done, but it's just going to be more and more difficult. The caveat to all this is really based on supply. Now, right now, have we successfully, I think the bigger question is, have we successfully administered vaccines to phase 1A well enough to move on to 1B? And that's a bigger question. And I don't think that's been publicized. I don't know the answer to that question. Have we vaccinated 50% of that phase 1A? Are we up to 70? I don't know what the benchmark is. I don't know what the goalpost is to move into the next phase. And so caveats here is that it could be pushed back a little bit. And it really will depend on whether or not there's a supply of vaccine. even if Johnson & Johnson gets approved and is able to submit next week, again, it just adds another layer of complexity to logistics and coordination of this vaccine for the states and federal agencies to get this new vaccine, and relearning of all of its safety profiles and its observational and which will need to be transmitted and given out to individuals before as part of the education. So I suspect there's going to be confusion, and there's going to be a little bit of chaos. And are we going to be able to, not just our agencies, but as all health organizations, our retail pharmacies going to be able to keep up? Because it's really opening the floodgates here a bit. So this slide was intended to be complex and very busy, and it'll take you a while to get through it, and that's intended because it's going to be a lot more people, and how many more, I don't know. If it's 1 million more, is it 2 million more? I don't know. And I just know that right now there's a limited supply of a vaccine just to go around for 1A. So lots of problems to figure out as we move forward. So what's going on throughout the United States? 72.4 million doses have been delivered. 56.3 million have actually been given. And this, currently we're averaging about 1.6 million doses per day, which has plateaued a little bit. Not to say that doses are not being delivered, they are. It's just not at the higher end volume that you would like to see. Long-term care facilities, total number of doses that have been administered, over 6 million doses, and that sounds about right. So, there was an estimation that there'd be about 3 to 4 million individuals living in long-term care facilities, and the staff that take care of individuals in that category. So there probably won't be a whole lot more new vaccines going into long-term care facilities. They may have reached their capacity right now. One thing, as vaccines are being administered throughout the entire country, I wanted to give folks a glimpse of where does the Indian Health Service, as a health agency that that oversees the health of federal, tribal, and urban Indian health programs throughout the country, where does IHS stand in its vaccine process? So one way to look at this is to look at, if you move to the right, you say people with 1+ doses per 100,000. So this really is looking at the rate of vaccinations. And then you see all of the states and jurisdictions and territories on the left-hand side. And so IHS, out of 63 jurisdictions and states, territories, IHS is actually number 9 in the country. And this may actually surprise people, but if people remember, IHS was one of the 5 federal agencies that was to get allotted vaccines separate from the states, separate from the 50 states. IHS, as a federal agency, got their own allotment, and as a result, we are the beneficiaries. GLIC is the beneficiary of being part of IHS, and so we are getting our vaccines through IHS, and so we are going at a pretty good pace here. And I think this is testament to the Indian Health Service and its ability to get these vaccines into Indian country, number 9 in the country. And I think that is a good thing to take notice of, that the federal agency that we are part of is doing right by the Native communities. So let's take a look at what's going on worldwide. Almost 110 million cases right now, 2.4 million fatalities here in the United States, 27.6 million cases. 335 tests have been conducted to date, and that's nearly just about one test per person here in the United States. 486,000 fatalities here in Wisconsin, 557,000 cases, 6,214 fatalities. What's going on in Indian country? So we have the February 16th as our reference point, the total number of tests being done aggregated to date, as well as the total positives aggregated to date. We see that 1,814,000 cases have been confirmed within the Indian Health Service. When we look at incremental change over time, as I present every week, every 7 days, I'm actually able to create the new cases from the week prior. So overall, the trend is going downwards, and when you look at the bottom, there's been 1,534 cases confirmed to date. I think that is a bit deceiving, and I would take that number with a grain of salt because what's happened in the past week? Well, there was a huge polar vortex that went right through the middle of the country, from North Dakota all the way down to Texas. And what normally in Oklahoma City, the area Oklahoma City includes Oklahoma and Kansas, there we're smack dab in the middle of the cold freeze. And we've heard on the news of all of the impact that has, and that has also a tremendous impact on probably people's ability to actually move and get out and actually get tested. So for Oklahoma City to go from almost 1,400 cases 1 week down to 383 cases the next week, I have a hard time believing that actually is the true number. And so that number of 1,534 actually may be the lower end, I suspect. So even if that was the case, even if we did average out, put in the same number as the week before, that still would mean about 1,000 more cases, which would put it at about 2,500. That's still lower than the week before. The trends have been going down. They have been going down for 6, 7 straight weeks. So I just feel the lower end of this number is needs to be taken with a grain of salt. So here you see the the area of Oklahoma City. That's Oklahoma and Kansas City. I'm sorry, Oklahoma and Kansas. Nashville, you would think Texas would be part of Oklahoma City. It's not. Texas is part of the Nashville area. So we know that this polar vortex has really taken a toll on a lot of people's lives down in Texas, but they're part of Nashville, and Oklahoma City has been the main driver of numbers here of late, and I'm sure that has a tremendous impact on their ability to service care and testing to individuals. So what's going on here in the Midwest, we see Illinois, 1,166,000 cases, nearly double than every other state in the region, and no dramatic changes have occurred in that area. Looking at the states, Michigan, Minnesota, Wisconsin, and the respective tribes, looking at the total confirmed cases over the past week, and what the rate of infection by population, 4.9 in Michigan, 6% in Minnesota, and 12.12% here in Wisconsin. I have to put an asterisk at Wisconsin, mainly because for some reason, the state, Wisconsin, has kind of reset and downgraded the number of native cases here in Wisconsin. Still a lot more than Michigan and Minnesota, but the incidence rates of infection here in Wisconsin still remains high. I don't know why the reset, the downgrading of numbers. It had not been explained as to why that has occurred, but it has. So I'm keeping this as a reference point. I suspect the numbers will continue to go up, and maybe they'll go back to what they were a couple weeks ago. But the trend does continue to go up here in Wisconsin. Information I just got in terms of vaccine distribution. So this is Bemidji area, that's Michigan, Minnesota, Wisconsin. This area has received about almost 41,000 doses. Almost 31 per 1,000 of those have actually been given out. We're part of that effort. We've been giving these vaccines. So that's a 75.5% rate of administering the vaccine. So whatever they get, they're turning around and giving them as fast as they can. Within the IHS overall, almost 700,000 doses has been allocated to the Indian Health Service. Almost 390,000 of those have actually been given out. So 55.8% of the doses that IHS has been allocated has actually been administered. So IHS has been quite effective and diligent in moving these vaccines and getting them to the sites that can get them into people's arms. 7-day average for Wisconsin as of February 17th is now 731. Now, when you look at this, you would it's skewed a little bit. So 731, if you just kind of imagine placing a line from 731 and try to go backwards in time, you would say that 9/16, September 6 would be about the equivalent of that. Well, it is, but it's off. The scaling is off a little bit. So if you were to extend, well, we get 731 cases on the average every day. If you scale that back, we're beyond the beginning of this huge surge. We're already all the way back to summertime numbers. Summertime numbers back in July 4th was about 750 cases on the average every day. So where we are now isn't just back to September, we're all the way back to even summertime on the average. So that's where we're at. And you can remember what summertime was, I hope. That's the kind of average numbers that we're seeing right now, and that continues to trend downwards. So that is remarkably good news for the activity that's going on here in Wisconsin. I always present this data table. It gets really busy and it takes a lot of time just to go through the numbers, but it goes from left to right, age group demographics of Wisconsin, the population of that age group, the number of cases by age group, hospitalizations, ICU, and deaths. So just like I take information from the IHS table, presenting it on a weekly basis, I get weekly numbers, and I can actually break it out by age, by hospitalization, type of hospitalization, and fatalities. So as you look on the right half of this, you can see that there are some trends that are occurring. We see that the number of cases, the age group of 60 and older, right below the green, you'll see 7,411. You'll see that the age group of 60 and older makes up 21.7% 5-6% of the cases. If you go to February 11th, you'll see that it's 20.4. If you go to February 17th, you'll see that it's 19.6. The trend is going down. It's not by leaps and bounds, but the trend appears to be going down. Hospitalization, 63 down to 60. ICU admissions, 90.9% down to 80%. So again, a marked decrease in number of cases as well as hospitalizations. Now the fatality rate has not dramatically changed, it's kind of plateaued. So, but there's always a delay. And again, this kind of reverts back to kind of my original statement. At what level, what benchmark, what watermark area do we have to reach in that phase 1A before we move on to 1B? And is that making sure 70% of that population gets vaccinated? Is it 80%? Is it 90% of the population of phase 1A get vaccinated before we move on? You know, it's a dilemma. It's a question. I haven't heard of what that was. There's no mention of what it is. I'm sure someone has that number, that level of administrating vaccines to that 1A at what what percentage that is. I think if we heard, let's say we're 90% of all 1A eligible individuals have gotten at least one dose, hey, that may be good enough to move on. But I haven't heard that, and so that's obviously a point of transparency. I think that would be helpful for all people to feel comfortable moving on to 1B. So I'll go through these quick, and this is the racial and ethnic breakouts of case rates here in Wisconsin. Natives have a 1.4 times higher case rate than non-Hispanic whites. Hospitalizations, natives are 2 times greater hospitalization than non-Hispanic whites. And the numbers are changing a little bit. Natives have 1.5 times greater death compared to non-Hispanic whites, 1.3 compared to blacks, and 1.8 times greater than Hispanics. And so as you go through these incidence rates of cases, we're third here in cases, we're second in hospitalizations, and we are at the top of fatality rate by COVID. So this is pretty dramatic, and it's significant, and why I come back to this question of 1A, at what rate of success can we move on, knowing that minority groups here in Wisconsin are heavily impacted by this. You know, we don't want to leave or not vaccinate people who are eligible and not have the opportunity because supplies have moved on to 1B. It's a question that I have, and I think needs to be answered, and how we address that, and how successful are we before we move on to the other age groups, especially since we know, looking at this table, that individuals younger, 59 and younger, obviously they have, you know, their case rate is there, their hospitalization is lower, but their fatality rate is much less than people 60 and older. So I feel it's a dilemma, it's a public health dilemma, and I think it needs to be addressed how we as a state are to move on from this. So with that, I'm going to turn this over to you, Mark and Jeremiah. Open this up for any discussions.
Dr. Ignace, a couple questions that come in between our shows is, as we get more into this, the different vaccines, well, hopefully they're going to be able to make a choice, you know, and with hopefully some help from their doctors. What vaccine are you using at the clinic when someone comes
and why is that your choice?
So we've had both vaccines in our clinic. Pfizer, obviously, they were first to be approved and first to be distributed. A good portion went out through Pfizer. So I personally got Pfizer. Once Moderna got approved, you have to remember back that Pfizer had a storage problem, and not all facilities had that deep freeze storage. Moderna could be kept in your freezer, and then you put it in your refrigerator, just like thawing meat out. You freeze it, you keep it. When you want to use it, you put it in the refrigerator, you de-thaw it, and then you can use it. And Moderna became a more practical approach to getting vaccines out. So we got first allotments with Pfizer, then everything after that has been Moderna. And what will be less hectic for all federal, tribal, urban centers is that Johnson & Johnson, you can keep it in the refrigerator and it actually keeps for a longer period of time. And it actually will be a better, we'll be able to store this in a longer capacity, and transportation will be a lot easier than Pfizer and Moderna has been. So Pfizer and Moderna right now, I'm sure next week we'll probably start seeing in the next 2 weeks, Johnson & Johnson.
So here's a question that came in again last week is just kind of thinking about our native population, thinking about things going up and down. We're now seeing things down, which is good news overall. But we also knew that upcoming is St. Patrick's Day. It's going to be next month on the 15th. I think that's number 4 in the United States for going out, socializing, drinking. And then Cinco de Mayo, which now precedes St. Patrick's Day for people going out and drinking. And there seems to be this correlation between drinking and COVID-19, which is interesting to me, meaning that one of the biggest days, I think number 1 or 2, is what they call Blackout Wednesday, which is the Wednesday before Thanksgiving.
So, I got it.
Yeah. So here's the question, is the socializing and the drinking, do you think, just from your practices, that when we do that kind of thing, oh man, I'm going to wear my mask, I'm going to go out, and I'm going to go out to Cinco de Mayo, St. Patrick's Day, can't wait, everything's moving down, that there may be a false sense of security in our community that's built by then, and that can get dangerous for us again. Any comments about that thinking, or is that kind of off? There's no relationship at all?
Well, there's no cause and effect to drinking to get COVID, but I think given the social circumstances by which they occur, yeah, it's pretty obvious. And so we know the rate of transmission is really high, especially in not small groups, but gatherings. Just the rate of infection and transmission just go up exponentially with more and more people in the same vicinity. So, it's going to be a problem moving forward, even with the introduction of vaccines right now. Like I mentioned, we're at that point where we were last summer in terms of rates, average cases per day. And even that was a contentious time. People were still, people were out and doing what people do during the summer, but I'm not comfortable in kind of I don't want to give people any false sense of security that given the rates of cases per week, or even the introduction of vaccines, that we're out of the woods just yet. We're nowhere close to that herd immunity level. So we haven't even gotten to 25% of the state of Wisconsin even either having had the infection or having enough people vaccinated. We're not, well, we're just kind of inching our way up 25% right now of the population. I think if we were closer to maybe over 50% of the state, I think people can relax a little bit, but still we're not at that point of demolishing this virus within your community.
So one question coming on the UK virus. I even hate calling it that, or the UK mutant. I don't know what the official name is, but I know there was one case in Waukesha that came up. That was maybe a week or two ago. Is that contained because we're much better at seeing what these things are, or is this something that you're concerned about that's going to be spreading? Because it seems like literature coming out is that particular strain is more contagious, has more serious effects.
So we've all seen the movie Jaws, right? You know, we see the fin running in the water. Well, that's basically what this, if I can equate this to, we've seen the fin cruising in the water. That's the B117. That's the UK variant strain of this virus. We've only seen the tip of the vein of the fin, and that's troubling because, as you know, in Jaws, it can come out of nowhere, and that's exactly what this virus and this strain can do. It can come out of nowhere. It can't pop up in Waukesha. That's not to say it can't show up in Menominee or Shawano County or Brown County, Outagamie, Ashland, you know, Dane County. It's going to happen. You know, so the fact that we've gotten one case, just know that there are sharks in the water, and it's present. And there's a delay between identifying an individual with the B117. Just know that if there's one, there's going to be more, and so this may be kind of the beginning of its presence in transmission, and that's why it's even more important. If we want to get ahead of these changes, you know, we maintain the practices that have been set forth, and we look at getting people vaccinated as soon as we can.
We're just a few days off of last Saturday in the city of Minneapolis. There was a love and healing round dance. The group that went ahead and did it, I believe the Minneapolis American Indian Center, they said, no, we're not going to host it. And so it was done elsewhere.
Mm-hmm.
And so this is on behalf of the nonprofits that are out here in Milwaukee, tribes that are looking to host events. I know that within ceremonies upcoming, there's conversations about, hey, you know, now that the numbers are down, and they had this event. Two questions in here. One is Indian Health Service looking into that event as maybe a model of something, hey, maybe not a lot of transmission happened, this is what they did right, or maybe this is what we can learn from it, or is this too much haste and other people wanting to follow along those same lines, saying, hey, they did it just a few miles off the border, now we can do it, and we're going to have ours next week. So as those kinds of thinking is happening in your mind, how far off is any kind of event like that safe? Or are there parameters that people can look to when they do gatherings, like so many people within so big of a room, that kind of stuff?
If this was indoors with let's say there was 100 people, or even if it was 50 people, you know, I would be really, really concerned about that event, and be concerned of a mini little outbreak. And it'll be a quick reminder to all of us as to maybe this wasn't such a good idea in doing. But we won't know, because it's not like you have an event, things are going to happen tomorrow. It's going to take 2 weeks for the effect, or if there will be any effect from this event. Now, with that being said, I understand people have cabin fever. People need to get out. We're tired. We're getting fatigued. I would feel much more comfortable in an outdoor event this summer, in May beyond. I think we need to put more distance with this vaccine, with all of the vaccines that are coming out. We just need more distance in getting vaccinated to a point where I would feel more comfortable in endorsing an event of that importance. I know it's important, and I know people need in our traditions warrant these events and to share in that moment, but it may be premature, is what I'm getting at.
The other question that is coming in is that people were looking at childhood vaccinations. And it was interesting because on this program, we've been talking about how children seem to be less likely to transfer the virus, that if they did get it, it was just a cough. And the parent question that I got last week at a grocery store was, if my kid already had it, it didn't mean a whole lot. Why should even sign them up for a vaccine? Because doesn't that make them more susceptible for something down the line when it's something they could more naturally fight off if they're just exposed to it at a young age, rather than getting them a vaccine and then hear, well, that's a vaccine, but once they're off it, man, it's gonna hit them like a ton of bricks when they're an adult. So maybe I'm better off not vaccinating a young child at all. So why do this?
Well, right now we don't know. We don't know if vaccinating younger people is even safe or effective. I think the history of this virus has told us that yes, young people do get it, but at a much lower rate than older people. And not only are there fewer hospitalizations, but rarely has there been any fatality. And so if little people are going to get it, they're going to get very mild symptoms. Rarely does it get to a point of severity where they would require any type of hospitalization. So, they may determine that kids don't need to get vaccinated just because of the minimal impact that's been observed to occur. Now, I know Pfizer right now, they've launched a vaccine trial in women, pregnant women. They're going to enroll 4,000 people, 4,000 women that are pregnant between the weeks of 24 and 34 weeks. So again, that's going to take time to find out the validity of that data and to determine how safe and efficacious that is. So, I mean, that's still an unanswered question right now, even for pregnant women.
And so I know that our programs are now to about 4 o'clock. So just a couple more questions. Do you know of any sheets or advisory lists out there? I know that for some ceremony, most of the attempt's going to be outside. I would imagine that inside protocols are different than outside protocols, or do we just go with what we've been told and how to behave inside? 6 foot distance, hand sanitizer, trying to limit objects that are touched in common, that kind of stuff. So any comments to that, or anything you might direct us towards?
That doesn't change for any indoor event. And you know, we've even seen like the Milwaukee Bucks. They've actually invited people into their stadium. We saw at the Pfizer Forum, we've seen the Green Bay Packers bring in people. Now, obviously following the rules and the distance and the guidance of social distancing and mask wearing, I think was kind of the essential part in that. But again, you know, we see that, you know, in a Packer outdoor events, with the distancing, you kind of really limit your exposure risk. Same with the Bucks Arena. They allowed 250 people. I think they're going to let 500 people in tonight, in the game tonight. So, but I watched that game on Tuesday, and I mean, they were like literally like not more than 6. They were like 50 feet away from each other. I mean, wearing masks, and so you couldn't even tell that they were in the stands. I mean, that's 250 people is not a lot when it holds 16,000 individuals. So you can see how, you know, professional arenas and teams are trying to get kind of integrate what level of acceptance can this can we do these events, sporting events, or even gatherings, you know, some of our more traditional cultural events, you know, they're doing this in an incremental approach. And, you know, I'm sure there's a lot of hesitancy on these teams' parts to do it just because of the unknown. We don't know at what level. Is it 25, 10%, 25, 30, 50% capacity? I mean, you know, time is going to let us know at what comfort level can we allow events to occur without risk to transmitting infections.
Last question for today, and then we're going to give it to you for our last words. We are at the top of the hour. I am seeing sweat lodges that have moved towards, well, we're just going to have one person in the sweat lodge at a time. That's the third time I've heard of this, and I was invited to one of them, meaning, hey, you don't have to worry because we have, as our sweat lodge is set up, you got your fire keeper, they're fine, they're far away. We got our conductor who remains the same, who's inside. And let's say we got 6, 8 people outside waiting their turn to go into the sweat lodge. That there seems to be some coalescence around that's the way to go now. I just not seeing it. And I'd like to get your kind of medical view on, is that the way to go, or are they missing something in figuring that this is safe?
So we know asymptomatic spread does occur. Now, the only way I see this could even possibly work would be if you completely opened it up after only one person being inside. You would have to completely open it up, air it completely out, and it would have to kind of start over. Now, I'm not saying that's the way to do it, or maybe it may be the safest way, but again, you're going to be doing sweats all day long. I mean, doing fewer numbers, but I get the need and the want to do it. I'm just really hesitant to say that's even a good idea, one at a time. I wouldn't do it personally.
It's my answer, and we can talk about that more, because I think this is going to come up more and more because word's starting to travel, and this is a native to native conversation. We need to address this directly.
The risk is too great.
Yeah. We will talk next week. Dr. Ignace, you have the last words of the day, and thank you for your patience for going over just a bit. And everyone, we'll see you next week. And Dr. Ignace, you have the last words. Thank you, everybody.
Thanks, Mark and Jeremiah. Thanks for the the time here. I know we're trying to condense this and get as much information as we possibly can. Vaccines are here. Johnson & Johnson is right around the corner. Just like Mark has been talking about, all of these, there's the need, the cultural need, the spiritual need for healing and wellness, and being able to connect. I get it and I understand. We all want that. We're all getting to a point of fatigue, and it's going to be frustrating because we're close. I think we're closer every day with vaccinations. We're getting closer every single day to a point where we can get to a new, that new normal. And that's really the goal, is to get back to that normal. But at the same time, it does involve everyone's participation. So with the introduction of Johnson & Johnson next week, there's going to be more opportunity, more vaccine out there this summer, if that is a goal, to be more involved, not only culturally, but traditionally and spiritually. This may be the window of opportunity for individuals to get that vaccine when called upon, and get that level of safety and protection to allow you to do all these things that have been missing in our lives. So right now we have to kind of maintain and keep up with our safety and our protection in the way that we have been. So I'll leave it at that. And so until next time, everyone, stay strong.